Thank you very much. You've covered quite a bit from many different perspectives, and it's a challenge to try to summarize, so I won't. I'm just going to mention some key messages or common themes that I heard, and then maybe try to push some questions before we open it up to more questions and a discussion. So one of the things that I heard, starting with Harvey but continuing across the board, is the need to talk differently about things. Whether about the flu versus influenza or seasonal versus pandemic, or how we talk about what we need, the strategies, so something different, and also to change our approach to thinking of strategies and who we engage and how we engage. That also involves talking differently. There's also a theme going down the line here on our panelists of stop doing the same things, talking to the same people, talking the same way, and doing things the same way. The idea of Harvey touched on organizations and commitment of resources, and we heard that as well, echoed by Gabrielle and Nikki and Dr. Ugarte, and then also the idea of not addressing outbreak preparedness, pandemics as another silo. That basically the need to think more broadly, and that multi-purpose investment, is worthwhile. I also heard from Gabrielle the success of other investments that were actually vertical and had a disease there that drove them. So I find myself a bit challenged on that. Earlier in the day, or maybe a bit yesterday, we talked about leveraging some of those investments for other things, but that also gets us into the lane of multi-purpose investments. I also heard said that we have some successes, that we've really have some successes under our belt for pandemics and others, and that we need to continue the progress and build on them. So we're not, the next steps or action are not necessarily all in a vacuum here. And then last thing is from Dr. Ugarte, the importance of that investment at the local level and institutions with credibility that are going to carry the water really in a day-to-day work, and also in whatever pandemic or outbreak, and that we do that. So I probably missed, I'm sure I missed, I missed quite a bit, because there was very rich thoughts and insights here. But just in terms of questions, and then also the need for investment in technologies and more progress in vaccines and antivirals and diagnostics, and that's key, obviously. So I think just to challenge, what would be the immediate next thing that you tackle? There's just so much that we have here. Harvey, what would be if you had to single out one of the things here and say, okay, maybe we start with that, not that the others are not important. Which of the three things that you put out in terms of communication, the public understanding, the organization and commitment, resources, world is ill-prepared, or the technologic, would you say, maybe let's start there?
If I wanted to do something that took advantage of what we now have, as Nikki Lurie said, you use the technologies and tools you have. I would emphasize the second point on organizational preparedness. If I wanted to lay the groundwork for a cultural improvement and response, I would focus on public understanding. If I wanted to be in the strongest position in 2 decades to have mastered the problem, I would start today to invest in the research and development of the key technologies. So which is the most urgent to do now depends a little bit on what is your time horizon for when you want and need to have that improvement available to you. And I think a sensible strategy is not to think only in the very immediate and not only in the very long term, but rather to make your investments in a way that does improve your immediate capacity while still doing enough to give you the possibility of dramatically better capacity looking ahead. So in the end, my response to your priority question would be really, when do you want that immediate investment to return a benefit? And if it's now, you better use the technologies and focus on organization.
Yeah, thank you. Fair. I think that's the challenge of we don't know exactly. We know we're going to need it. Yeah, but so it's incremental progress at the same time. Yeah. Yeah.
We need all of these.
We need all of them.
But you asked about the priority now, and you have to have a reason. I think it would be fine if for some people to say that they know that we have to be able to respond today. They know that it matters that we improve organization. Their particular interest, their particular focus, their aim is to solve the problem technically as a whole, and therefore they invest in the research. And it would be equally valid, I think, for someone to say, as important as that could be in the long term, my priority right now is to protect the public next year. And that's going to require the following adjustments.
Gabrielle, if I can push a little bit, I think you challenged us here by saying, we do need a political strategy and investment health diplomacy, and a bit different than what we've been doing, right? I mean, yeah, and so I guess who are there players that we need to engage and talk to that we're not, who is not at the table in these conversations that needs to be there to start off?
Thank you. Well, first of all, I thought you did an excellent job summarizing a very broad thing, and my answer to which I would start with is behaving differently. And so to answer then your second question, what I think that looks like is, in a perfect world, I would say, okay, let's all reconvene tomorrow and do a mapping of what our priorities are and what the targets are. And if we do a network mapping across everyone in this room, we can probably have some pretty good connections to many of the people we're targeting. On the silo issue and the issue of vertical funding, the examples that I gave where we had those big increases of funding were kind of a different era where that was the flavor then. But I would point out all of the mechanisms that I recommended advocating for funding or strengthening, those all exist. And so you could see it as a silo, but they do exist. They have been created. They just need to be strengthened or additionally funded or improved on. So I don't think it would be wise in any way to say, let's set up a global fund for outbreak preparedness. That would not be a good political strategy at all. But beefing up existing mechanisms, I think, is something that is a lot more palatable. And so the behavior that I would do differently is coming together and developing a strategy to do that and really work on a political strategy.
Okay, thank you. And Nikki, I like your idea of thinking more broadly, multi-purpose investment systems, whether it's surveillance and response, et cetera. It makes sense, but it doesn't get traction. It's, capacity. It's just bland and seems to be not appealing to, funders. And so just a question of how would you go about making the case for, multi-purpose investment of that sort?
So I guess I would make 2 points. One is one of the challenges that we have is that what we are trying to do, what we in developed countries think needs to have happen, isn't necessarily what the countries themselves feel like they need. And so I think there's a really big challenge of figuring out, sort of in this multi-purpose way, how we meet, to your question to Harvey, the immediate day-to-day needs of populations that are less fortunate, and how we use the capacities we have now to pivot them to the day-to-day needs, to strengthen them, to make them endure, so that you can have this multi-purpose perspective. And I guess I think that some of the players who are not typically at the table, i.e. not typically the disease funders or the public health folks, but private sector players, businesses, others, I think see some of this a little bit more clearly. They've certainly seen it in operations, logistics, supply chain, other kinds of things that are really relevant core capabilities that we need to respond to an outbreak, deploy vaccine, whatever, but also to take care of their core business needs. So I actually don't think it's that hard, but I don't think that we've brought people together to articulate the cases as clearly as we have. And we always view those people, the chronic disease people, as other, for example. Even thinking about doing vaccine trials now and deploying vaccine, as I've been thinking about for CEPI. Well, where's most of the capacity building right now coming for doing vaccine trials? A huge amount is coming from NCI and developing cancer vaccines and testing them in developing countries. A huge amount is coming from private sector companies. None of these parties talk to each other. And to Gabrielle's point about the network mapping, there's sort of so much competition for credit that people keep this stuff all to themselves until they're in a position to be able to take credit for it, rather than sharing, planning, leveraging one another's resources. Now, to some extent, that's just human nature, and I don't know how to tell you to change that, but to another extent, some transparency, sunlight, network mapping about who's doing what, and maybe just getting 2 or 3 of the key players in the room to get started with this, I think is where I'd start, to get that done. Sibling rivalry is a really powerful force, and it can be often used for good, and this is a place where I would use it for good.
Great, thank you. And Dr. Ugarte, my question, finally, I much appreciated your comments and your perspective, and thank you for being here. You obviously had more immediate issues and challenge to deal with. So thanks for being here. You touched on, and one thing that we didn't discuss, so you touched on a multisectorial approach needed. And I think as we think of pandemic and other outbreaks, One Health approach is so key. So is there anything related to that you might want to contribute in terms of the need to bring, other sectors to the table as we go forward?
Yes, I think the first thing that we need to do is to recognize that we do not own the pandemic in the health sector. It is beyond that. It is clear that the health emergencies, communicable diseases, have huge impact in the economy and the policy and in many other sectors rather than the health sector. Mm-hmm. So beginning with that, and it's not easy to do, because we are the ones who have to call the decisions. We are the ones who know how the disease is communicated, how the disease is happening, how the research, everything, every call has to come to us. And I think there is the biggest deterrent for multisectoral coordination. But also there is, because of that, and because of this mantra of big scientific approach to that, the other institutions, particularly the emergency management institutions, are scared to participate. And they don't want to to take the responsibility, even though all the plans for pandemic influenza in all the countries consider that the multisectoral emergency management institutions should take the lead. But they didn't. And they don't. So I think that is one of the components that we need to recognize. I remember when cholera epidemic began in Peru in 91, the first thing that I did was call the general who was in charge of civil defense. And he said, well, come on, this is an epidemic, this is not an emergency. Yep. And the president called us back saying, okay, you deal with it, I don't want to know about it. So those are a type of aspects that are deterrents. We need to work a lot with those other actors, having them also involved in the solution, because the solution will come from them. Even the health, as you know, well-being, health is not a product of the health sector. The ministries of health are organized as the ministries of diseases, not the ministries of health. So health is a product of education, transportation, economy, and other sectors. So we need to recognize that. And that is, I think, the approach that I would like to share with you.
Thank you. Before we open it up for questions, any of our panelists want to add anything after hearing the comments and perspectives from others? Harvey, do you want to?
Could I ask a question?
Sure.
Okay, because
Go ahead.
I have many questions for all, but I was especially trying to think, Gabriel, in your comments about the importance of essentially political action, that in many instances in the American health experience, it's a disease group that has the initial motivation, persistence, and passion to evoke political response. We don't have that. So what is our alternative? How would you mobilize the public side of the effort to promote a political movement around this agenda that you described?
So I think despite not having sort of a natural constituency, there are a number of groups that that are very interested in this. And Carolyn Reynolds and I convene a advocacy working group, which is quite informal at this point, but there's at least half a dozen advocacy organizations and philanthropists who are very interested in advocacy. One of the challenges is that none of the philanthropists have put funding toward it yet. So we haven't been able to move beyond the informal convening beyond that. But I think with a little bit of money, it would not be that hard to take that group that exists with, as I said, all the connections of people in this room and other rooms like that. And then there's also a real plethora, let's look at the U.S. context, of former U.S. government officials who are very passionate about this concept, whether it's Ron Klain, Larry Summers, Mike Morrill, the former, I think, acting CIA director. They've all spoken out about the importance of this. And obviously, we would want to make sure any high-level group would be bipartisan to appeal to the various constituencies. But I think there's no shortage of people to be in this constituency or coalition. What has been lacking is a little bit of funding to accelerate that.
Anything else any of the other panelists would like to add or ask of each other? Yes, Dr. Zero.
I was just very struck by your question to Harvey and his response. You know, any investor within an investment portfolio invests so that you have returns on investment at different times in the short, medium, and long term. And I think as we think about the investment portfolio here, we need to think about, you know, today's short-term investments in incremental change are tomorrow's system. And yet we also need the long-term investment type pieces. The challenge that's always so difficult is, to Gabrielle's point, that the political leaders, right, who are those who are responsible for making those investments or not making those investments, aren't around in the 20-year time frame to either have the accountability for not making them or to get the credit for making them. And so it's very hard for us to think often about some of those longer term pieces. I was really struck by the great set of interchanges with the two of you in that regard. And with Ciro's incredible focus on, we have problems today, but solving those problems today will be tomorrow's improved system. So
I have a comment on the antivirals and the stockpile of antivirals. Why? Because most of the countries, at least the developing countries, do not have the luxury of have that in place while waiting until the pandemic influenza will happen. Actually, many of those health officers that took the decision to purchase and storage antivirals went to the court because they purchased things that were not used during the pandemic, and the cost was humongous, and then all expired, and everything. So I'm kind of curious of how can we move on that, because I truly believe that we need to go towards that, and that is a critical aspect in pandemic influenza. Without that, probably we won't be able to cope. But then how can we deliver that in those contexts?
Great. Well, I think it's time to open it up for questions from the room. Keiji?
Thanks, Rima. I'd like to follow up on Harvey's question to Gabrielle and sort of push it a little bit. I think that in the last couple of years, I've focused a lot on antimicrobial resistance. And in many ways, it was an analogous situation to what we are now, but with some differences. What we wanted to do was to take something which had been around for a long time and was really worrying many doctors and nurses and scientists and so on, and then change the paradigm. And it worked in many ways. It got to the United Nations and so on. And en route in doing that, one of the questions which came up, and this is coming up from countries and so on, is, well, this is old stuff. Why do you want our heads of states to address something which is old? So we had a kind of convincing answer to that, which is that it's really bad now. It's threatening people, it's threatening the basis for modern medicine, it's threatening food supply and food security, and it has broad support from both, from a number of different sectors. And so those things were useful, not sufficient, but useful. There are two X factors that came into it. One of them was getting multisectoral support to a deeper level. The other X factor was to have David Cameron provide political muscle. And the UK basically engaged its diplomatic services. And so not only politicizing an issue, but engaging the political side of it and so on. And I, like you, completely feel that public health is political. And I think that I grew up in a world where public health was surveillance and technical issues, but it's not. It really is very political. When I look at pandemic preparedness, I think, what is the answer to why now? And I think we have a partial answer to it, but we don't have a complete answer which resonates. If I ask the question, do we have full support of the major scientific technical bodies, I think the answer is probably yes. There is strong support from the agencies, from different groups. But if I say, do we have multisectoral support, the answer is no. And do we have a political champion, the answer is no. So it's sort of a half deck. So with a half deck, can you move to really change this from being a technical issue, trying to get support, to something which is political?
So I have a lot of answers, but one thing I think we need to do is recruit that political champion. And, I'll go back to the CEPI example. That was really a joint initiative of Norway and Wellcome Trust. And then they leveraged their relationships to bring others to the table. And so again, if we went back to just the mapping in this room or the list of former officials that I said a moment ago, I strongly believe that we could recruit a political champion that could help do that diplomatic outreach kind of at the senior government official level. So that's one answer. The second answer is that I think every country and every political environment is going to be different, and you need to tailor it toward that. So if there's a leader that really feels like this is old news, kind of at an executive level, perhaps you target a congressional or legislative champion. And, sometimes it won't work, but I am not convinced that we've tried in a robust way to really think about a political strategy around this. And I guess I have to say, coming from an environment where I was an advocacy funder, it's been really interesting and surprising to me that despite the sort of level of interest in this topic in meetings like this, no one has stepped forward to support advocacy in this way. And going to the Harvey and Nikki's points on your investment portfolio, I think advocacy is a really critical investment in an investment portfolio because it has the biggest leverage play. You can invest $1 million in advocacy and get an ROI of 500 times that. And so I think there's a couple pieces missing, but again, I'm optimistic that those are barriers that could be overcome. Go ahead. Come on.
Thanks for that very interesting set of remarks. And I was particularly delighted to hear Nikki and Ciro's comments around health system strengthening and the importance of a multisectoral approach. And I would say that as one of the recent people in the room who works on health systems and multisectoral work. But I do sort of, from the last 2 days in another meeting, see a tension between, on the one hand, sort of saying, well, there's a very specific technical agenda here around diagnostics, vaccines, improving surveillance capacity. We know what we need to do, we just need to get the resources and do it. We have a traditional community that does that. And that sort of discussion that actually, no, this is a bigger deal. We need all of health systems, we need all of society, we need everyone at the table. And I think there's a real tension there, because I'm really struck, for example, the last 2 days, we've barely heard the phrase universal health coverage mentioned. And I would say that, sure, and I understand, we're in a particular political context here, but globally, I mean, that's a big deal, right? Countries are moving, they're increasing their health spending, their health systems. Private sector spending in health systems is increasing. And I would argue that you can't get universal health coverage if your health system cannot deliver the ability to prepare for and respond to threats, to outbreaks and others. And I sort of pose the question to this community, which I'm a sort of marginal member who dabbles in and out of. I mean, is there really this desire to have everyone at the table and to leverage this as a mainstream activity, get the $10 trillion industry online, get the other sectors? Or is there really, well, actually, we know what to do, we just need to get the resources and the political will? And it's not either or, but if you do want everyone else at the table, you need to cede some power and cede some leadership. When we talk about multisectoral work, we often talk about this issue of health imperialism, where the health sector instrumentalizes other sectors for their own interests, right? Without respecting the interests that the other sectors have to bring to the table. There's a similar aspect here, I think, with the interaction with health systems, where we want the capacities of health systems, we want that interest, but is this community really interested in recognizing that the mainstream interests around health system strengthening? And so I wondered, whether the panel has some further reflections on that, is that it's not either or, maybe it needs both. But I think if you're going to get the sort of broader community and health systems and other sectors at the table, there probably does need to be a change in the messaging and in the way and the means of engagement.
Well, I think you've identified a really important tension, and I think it is kind of ever present. If I think about when I first got into work on preparedness and work on public health, and I looked at sort of what was a public health system supposed to do, people would say, if you've seen one health department, you've seen one health department, et cetera. And over time, people work to define, well, what are the core capacities that are needed? In the US, there were 10. In the Pahar region, there were 12. And being able to respond to emergencies and disasters was one of them. Interestingly, it was nowhere near on the radar screen in the US. But I think if we're going to talk about then what are the core capacities that are needed to get to universal health coverage or to do health system strengthening, all the things that we're talking about in the technical areas fit in pretty nicely. But I think you're right, they're not, there is some power sharing or information and influence sharing that has to go on to develop that. But you have to build those core capabilities to be able to do all those things regardless of what you're doing. Just when I came in, there was a bunch of talk from the tables that I didn't totally follow about the FEMA model. But having worked very close, is there somebody here from FEMA? Oh, great. Hi. So one of the things I appreciated most in my interactions with FEMA is not that they ran things, but that they got all the sectors, they had a structure that got all of the sectors around the table: transportation, electricity, food, water, commerce, health, you name it. It wasn't that health was up here and everybody was down there, but it was that you really managed the interaction of all of those different sectors. And maybe because universal health coverage and health system strengthening have the name health, we exclude all those other sectors? I don't know, but I think that sort of coordination, recognition, and respect of the disciplines, parties, and sectors is something that's going to be needed to move us forward.
Right.
I would like to comment on that.
Sure, go ahead.
I think I didn't say that this intersectoral work is easy. It is difficult. and I mentioned why it's difficult. But for the health systems strengthening, there are, yes, the public health essential functions that is part, and now it's beyond every region in the world is now applying to that and towards universal health. We have in the Americas some issues with that. Not only universal health coverage, but universal health access. So we call it universal health, okay? It's not to have the problem. But I think we need to find what is in need for the health systems area of work from the emergencies perspective. And KG mentioned the antimicrobial resistance that is core to the health systems. Infection prevention and control that is core to the health systems. And so there are many aspects that that area of work may benefit from the work in emergency preparedness for pandemic influenza, etc. And we need to share those. And when we reach that level of mutual benefit, I think we are better off.
Yeah, go ahead.
Just building on what Nikki described as the FEMA model, that's the exact model that I believe is needed and why I recommended a UNSG coordinating mechanism, because WHO doesn't have the mandate to bring all those people together around the table. And as we saw with Ebola, the Secretary General had to create something. And so let's not reinvent the wheel every time. Let's create what we know is needed, get it on a preparedness stance where they're doing the drills and the simulations, and have the Rolodex of names ready to call when they need them. So I think that's the exact rationale for why you need something at a higher level than WHO.
Excellent. Next question, Rafael.
Yes, thank you also for a very stimulating panel. So let me just go back here. Sorry. I want to build on one of the points that Nicole made about the focus on culture and community engagement and the importance of bringing more specifically social science into outbreak preparedness and response. I think we've made a lot of progress over the last 2-3 years working with WHO, and I represent UNICEF, by the way. with WHO trying to strengthen this component in some of the global mechanisms. For instance, in the GORN, there's now a working group that is looking at these issues. We are working very closely with WHO to bring anthropological capacity to support the response. We set up an online platform that allows us to produce rapid synthesis of evidence and data on social and behavioral dynamics and so on. But these are small steps in my view. I think we still need a lot more investment in this area. So I would love to hear your thoughts in terms of what else or how do we strengthen this component? Because my perception is that while we all recognize that it is very important, the level of investment is still very low and is not commensurate with the need that is clearly evident at field level. So where is the gap there in terms of the commitment and investments from your perspective? And then I'd like to connect that to one of the points that Ciro made as well in terms of what this means at country level. So for instance, when it comes to countries and both state and local, health promotion units, which would be the primary focal point for this kind of work, tend to be very under-resourced, tend to be rather weak in these systems. So how do we also bring that focus in terms of the proper investments in these areas? Because I would argue that in terms of preparedness, that role is so critical because trust and engagement needs to be done prior to the actual outbreak and the response. I mean, it's a lot easier to bring in supplies and other kinds of support elements, but it's very difficult to build trust in a matter of days. So how do we strengthen that engagement dimension through the preparedness work? And that obviously would require a lot more capacity on this particular area.
Very easy question. When you don't have resources, of course, the other aspect is the political support and strategic support. And sometimes that is even has a bigger impact than the resources that you can pour into a local level. So involving the decision makers at the local level and having them part of the solution is one of the biggest areas that we still are lagging, but it is showing that we can control yellow fever in Brazil, measles in Venezuela, and other diseases in other countries when those local levels are engaged with the other higher levels, engaged, not necessarily receiving resources and everything. But it's not easy. Okay? Why? Because in several occasions, especially in the decentralized countries, you cannot just land in a local level without having the proper clearance from the other levels. And in that regards, our organization and your organization managed to do that in support to the member states. And if something is happening in those decentralized countries now, and it's going better than before, is because there is these bridges along this health diplomacy and other actors that are getting involved in order to reach those levels that are not easily reachable through the normal mechanisms.
Now, I think you've identified an important issue, and I think people think about, oh my God, now we have to do the same thing for social science that we did in all these other fields, and it's a gigantic investment, and they sort of glaze over. And as we all know, in highly technical settings, social science doesn't get a whole lot of support. But I would argue that there are social scientists all over the place, or people with those skills, that we haven't tapped into and we haven't deployed. Harvey talked about communications. And in order to communicate effectively, you have to understand what it is that people are thinking and feeling. There are good playbooks for doing all that. All over the world, companies sell stuff to people that they don't need. there's behavioral economics there, there's marketing there. There's a lot of expertise. We haven't been, I don't think, as creative as we might be about how to tap into that. And then I think we're going to need, and I think we're on a good path to doing that, some pretty good sort of just-in-time training, because it's not like you can take somebody from the UK and Canada and go stick them into a country where they look really different and they don't speak the language and expect they're going to function as a social scientist. But I think that there are some really innovative approaches to training, and especially as technology is improving, that could help us catapult this forward quickly. What I wouldn't want to see us do is try to use the same model for this that we use to train an international corps of epidemiologists or an international corps of something else. I think we probably can do things differently and more creatively.
Okay, last question, I think.
Thank you very much. Thanks to all the panelists for really fascinating interventions that I think are very appropriate to end this day and a half of reflection. I think my question is probably addressed to Dr. Ugarte. And I'm wondering, do you feel you have adequate information about all of those actors on the spider web, what they're doing, what they're planning to do, what they're able to do? Is there enough information there to coordinate, whether that's a kind of passive or an active type of coordination? And the reason I ask this is because when Gabrielle and I were working on the paper that she kindly mentioned, one of the papers, the one that was published in August of this year, one of the big challenges we had was just trying to figure out who's doing what. And there are thousands of actors. And we were trying to look globally across all of these different issue areas that she mentioned. And we were frustrated, and this frustration is not new, but there's no place you can go to find that out, right? And I think, Dr. Ugarte, in your presentation, you emphasized very much the importance of coordination during crises. And I think that's also when we see the big gaps in coordination, when we see the most wasteful and frustrating sort of duplication of efforts or working at cross purposes. But it seems to me that coordination between crises is also important. And do we have enough information at our fingertips to encourage global coordination or regional coordination? And if we don't have that information, who can gather it? How do we get that? How do we help everyone to know better what others are doing? Because I think that also helps with, for example, autonomous self-organizing type of coordination, which helps a little bit with the problem that you very concisely identified as nobody wanting to be coordinated.
For the institutions that are in the spider web, yes, we do have information, but it is not enough. Having the information or the capacity is sometimes is not related with the will of those organizations to coordinate, to participate, or to put into the table on the table their contributions to something that is common. So that is the problem. There is where these exchanges and negotiation comes into place. And when I mention this, it is not only related to emergency response. It is bigger in emergency response, and it is even more challenging when you do not work with them on a daily basis. If you don't know the person who is in charge of those areas. And one of the reasons that we are in tomorrow's meeting, we're inviting the UN, UNHCR, IOM, and several other institutions to the meeting with the ministers of health, because they never deal with them directly. And if they are not part of the equation of the multisectorial level and the decision level, UNHCR, IOM, and others are discussing with the presidents, with the ministers of finances, with the ministers of foreign affairs, and the decisions are made. The ministers of health are not part of those discussions. So we need to bring them up to the level of being engaged with that. So that is the type of work that we do in a normal time, also in emergencies, trying to have those people around. It is not easy. As I said, in preparedness, sometimes work very well. And during emergencies, the visibility The flag, the cap, the vest are more important than the actual value of the contribution. So you see sometimes certain photographs or certain images or that are nothing to do with reality. And actually, I want to share one episode during the pandemic influenza in Mexico. We had to manage every actor of the GORN take out their vests and their caps, because the only ones that didn't have were the nationals, and the nationals were responding, are in charge of the response. The other was only contributions. As you know, in the media during emergencies, you see a plane arriving with certain goods, where that's a very tiny proportion of the response. Where are the nationals? Where are the thousands of healthcare workers and hospitals? They are invisible, because this international organization or others are highly visible, and that's a big problem. There is where, I think, in the UN already decided that the big health emergencies, it is the UN Secretary General who will take the decision. It will not be WHO. So that is a decision taken already.
Great, thank you, and thank you all. This brings us to the end of the session. Please join me in thanking our speakers. Excellent, excellent.